I'm Dr. Oren Michaeli. I'm a peripheral nerve surgeon. For this topic, actually, it's important to mention I also happen to be a board-certified general surgeon, even though I don't do general surgery anymore. We're going to talk about chronic pain after a hernia repair. While many surgeons will say that they don't have any pain, the literature, actually the board answer for chronic pain after hernia surgery, 7%. When you have a hernia, you have a weakness in your abdominal wall. Well, I guess it could be anywhere, but we're going to go with regular groin hernias. What they'll do is they'll repair the hernia and then they put a mesh. So if you're coming from the anterior approach, right? So you're making an open hernia repair, right? The classic hernia repair. Oftentimes you'll find the ilioinguinal nerve because it's right in your surgical field. You try not to damage it, right? Some surgeons will actually cut it, which can then form a neuroma, because we know that if we cut a nerve and we don't fix it, it will form a neuroma almost 100% of the time. They'll fix the hernia, then they put a mesh over. And the point of the mesh is actually for it to scar into place. That is actually how it's supposed to function. The problem is that we also know that if nerves can't move, they cause pain. So we're functionally scarring this nerve into place, and then it's causing pain. The general surgery training, they often teach about triple neurectomies, where you cut all the nerves that could be implicated. So the iliohypogastric, the ilioinguinal, and the genitofemoral nerve. So what is the correct approach for this? Well, you should do a neurolysis. You try to remove the nerve from the mesh and then protect the nerve. So I'll often do that with a series of fat grafting and nerve wrapping. The same issue can happen even laparoscopically. Unfortunately, laparoscopically, we have a lot less options in terms of gentle nerve handling. So I think the best bet is really to prevent it from forming by protecting the nerve when you're placing the mesh. In my case, if the general surgeon happens to work in the same hospital as me, they call me. I happen to be robotically trained. I'm happy to assist. Unfortunately, I think most people, if you're watching this video, it's already a little too late for that. A nerve reconstruction is really going to be the best way about this. For the nerve reconstruction, we could do a TMR, we can do an RPNI. I encourage you to look at the videos for these, or VRPNI, or a simple neurolysis. If we do end up doing a nerve reconstructive procedure, we avoid getting into the mesh. You might have a little bit of a numb spot because we do have to cut the nerves, but we do reconstruct them in the end, and that decreases your chance of a re-neuroma formation. You go home the same day, fairly simple surgery. You may feel the results instantaneously, but some patients, it could take up to 3 months to know where they're going to land. Fairly well tolerated, very little downtime, showering within 2 days, back to physical activity in no time. Unlike your hernia surgery where you had to let it scar and you were told not to walk for too long, not to stand for too long, just due to the effects of gravity on the mesh, here you're walking right away, you're moving right away. We are not slowing down for a second.